right. Well, thank you everyone for coming. As I think all of you know, I am Joshua Bengal. I'm the Government Relations Director for the Medical Society. And welcome to the, I think now, fifth iteration of our new MSNJ monthly lecture series. This series has addressed really a wide variety of topics over the last 5 or so months that we've been running it. We've covered topics ranging from artificial intelligence or augmented intelligence in medicine to the FTC's new non-compete rule, which I should also update everyone is currently stayed. And today or tonight, we will be hearing from Jeff Coughlin, the Assistant Director for Federal Affairs at the American Medical Association, the AMA. We will be hearing about our next topic, and that is information blocking and HHS's new information blocking rule. Now, the goal of this lecture series, really the goal of the series generally, is to build up a corpus of educational material that is accessible to MSNJ members and others for long after each lecture is given. So I just want to make sure everybody knows that this is being recorded. And that it may be, or will very likely be, sent out to those who want to learn more about these topics at a later date. All right, so let's turn to information blocking. So Jeff is going to be able to share a lot more about this, but I have to say, the HHS information blocking rule, I am very much not an expert on it. It was news to me relatively recently, learning about this rule. But I will say I got very interested in it when I learned that, and this is sort of the classic or the most concerning example of how this rule might be employed, and what made me really excited to learn about it. If there is a patient, if you have a patient who goes to the emergency room on a Saturday at 11 o'clock at night, and the physician in that emergency room is attempting to pull up your patient's records and is unable to do so, there is a possibility that you, as the patient's general treating physician, could face an information blocking charge from the Department of, from HHS, from this federal agency. As soon as I found out that the risks were that great and that the requirements to make information available were that strenuous, I would say, I realized that this is really a critical piece of education that Jeff is going to offer us tonight. I should also add that the Medical Society's information sharing system, known as One Health New Jersey, is a surefire way to avoid a charge of information blocking. So if after watching this lecture you are concerned, but interested in learning about ways to avoid any information blocking charges, please reach out to the Medical Society to learn about One Health New Jersey and what it offers. All right, without further ado, I will introduce our speaker, Jeff Coughlin. So Jeff is an experienced public policy professional who currently works on the federal affairs team at the AMA, where he specializes in health IT related issues. He advocates on these issues before federal agencies and Congress alike. Before working at the AMA, he led the Healthcare Information and Management Systems Society. It's a mouthful, but it's shortened generally to be known as HIMSS. He led HIMSS efforts to build stronger relationships with both federal agencies and other bodies, and helped build a nation network of advocates in the area of health IT. Before joining HIMSS, Jeff held high-level positions at the Marwood Group and in the U.S. Department of Health and Human Services, where he worked at the intersection of legislation, information technology, and advocacy. Jeff holds a master's degree in public policy from the College of William and Mary and a bachelor's in political science from Providence College. And so, without further ado, I will turn it over to Jeff. And Jeff, you're on mute. Not sure if you know.
Great, thank you. I appreciate it, Josh. I'm happy to be here tonight. Let me just put this in. All right, everyone can see my slides, I assume?
Yep, looks good.
Okay, awesome. All right, so thanks very much for the invitation to come here tonight and for the nice introduction. So I am going to, as Josh said, I'm going to talk to you about information blocking and kind of interoperability in general, and happy to keep this somewhat informal. So if folks do have questions along the way, please just let me know. I will try to monitor the chat, but just feel free to break into to the discussion as well. If you have a question, you can just raise your hand. So in terms of, I just wanted to start off this presentation with a small disclaimer. I'm going to present this information to the best of my ability and knowledge. This is a kind of a very dynamic topic, and statutes and rules and regulations related to information blocking frequently do change and are updated by the Department of Health and Human Services and other agencies. So we just want to make sure that folks understand that this is not medical, legal, financial, or other professional advice, and we encourage you to consult a professional advisor for any such advice. So as I said, I'm going to talk a little bit about interoperability and information blocking, then jump into the disincentives, and then talk about kind of how an investigation around information blocking may occur. So investigations will be kind of in conjunction between the HHS Office of Inspector General and the new HHS Office of the National Coordinator, which recently changed its name to the Assistant Secretary for Technology Policy and the Office of the National Coordinator for Health IT. And then I'll talk about physician practices, and then there should be plenty of time at the end for Q&A. So jumping right in, folks probably have seen this in action in terms of how health IT and the adoption of health IT by of certified health IT, I should specify, has really skyrocketed in the past 12, 15 years. So as of 2021, which is the last year that there is kind of data from the Office of the National Coordinator, about 78% of physicians have adopted a certified electronic health record. So you can see right there that hospitals have had kind of similar levels of increase. Hospitals are closer between anywhere between 90 and 96% or so of adoption of electronic health records. But I think it is, you can see from 2008 to 2021, it's a huge increase, all the way from 17% in 2008 to 78% in 2021. So kudos to you all as physicians in terms of adopting electronic health records. And just to take a quick step back and talk about where we have come from and how the interoperability landscape has evolved. So things really started related to healthcare data exchange and interoperability, kind of came to the forefront in 1996 with the kind of passage of the HIPAA rules. And then and things have moved forward in the legislative direction with the establishment of the Office of the National Coordinator back in 2004 by executive order from the Bush administration, the Bush 2 administration, I should say, and then the passage of the HITECH Act in 2008, which created the Meaningful Use EHR incentive program that has kind of provided the basis for the kind of explosion of adoption of certified electronic health records by hospitals and by physicians. So that kind of $35 billion investment really has translated into that growth in the adoption of certified health IT. The other thing that I'll point out here was that in 2016, right at the tail end of the Obama administration, the second Obama term, was the passage of the 21st Century Cures Act. So 21st Century Cures included the provisions related to information blocking and kind of set the parameters that HHS, the Department of Health and Human Services, has been using to kind of move forward on implementing the vision that was agreed to in 21st Century Cures. So when we talk about information blocking, there are really three categories of actors. So the first are health information networks or health information exchanges. Second is the health IT developers or certified health IT. And the third, which we'll spend the bulk of our time talking about tonight, is really healthcare providers. So a couple of quick caveats to just mention here when we talk about HINs and HIEs. So you'll notice here in terms of the regulated actors, you'll notice that healthcare payers are not included here. However, a healthcare payer could be acting in the capacity of a health information network or health information exchange. So there could be some functions of payers that would come under come into the kind of jurisdiction of the information blocking rules. So that's just something to keep in mind in a broader sense. And then when we talk about health IT developers or certified health IT, if a health IT developer has any certified IT in its kind of broad portfolio, then it is a regulated actor. So even if it's impacted by kind of a non-piece of certified IT, something that the Office of the National Coordinator has as part of its certification program, then that vendor, that developer of health IT, is included as a regulated actor. The information blocking definition is kind of broken up into three parts. In the the first piece is kind of the most important, and what we're talking about related to information blocking is a practice that is likely to interfere with the access, exchange, or use of electronic health information. So that's kind of important to note, is likely to interfere with access, exchange, or use of electronic health information. However, the knowledge standard for the regulated actors differs here. So for a health IT developer or health information network, health information exchange, that regulated actor knows or should know that a practice that they are engaging in is likely to interfere with the access, exchange, or use. On the other hand, a healthcare provider has a different knowledge standard. That provider has to know that such a practice is unreasonable and likely to interfere. So you can see the difference there. I think that this was kind of put into place because health IT developers, health information networks, and exchanges have a higher level of IT expertise and probably understand the IT environment a little bit better than generally speaking, than a healthcare provider. So that's why there's the different knowledge standards in terms of knows and shoulds knows versus knows. So the inclusion of information blocking is and the terminology around information blocking is intentional. So what we're talking about related to information blocking has kind of morphed into broader discussions around information sharing. So in information blocking is in a kind of a negative sense in terms of information should be shared broadly. That is kind of the underlying assumption that HHS is making. Information should be shared on behalf of a patient between providers and networks and exchanges and so on. So if that information cannot be broadly shared, and there is the possibility for these 9 different exceptions. So when an actor's practice meets one of these exceptions, it would not be considered information blocking or in terms of what's required here. So there are kind of different kinds of exceptions, and I have shorter, brief definitions of each of the 9 exceptions here, but I think some overarching points are important to mention here. So again, if an actor can meet one of these exceptions, and then it will not be considered information blocking. However, if there are cases when one of these when a practice does not meet any of the exceptions, it does not automatically mean that's going to be considered information blocking and kind of regulated as such. So all information blocking complaints, allegations are going to be evaluated on kind of a case-by-case basis. So that's just something important to keep in mind. So there are these 9 exceptions are kind of spelled out here, and these have been kind of defined. And there are some links that I have at the end of the presentation that provides a lot more background, a lot more detail around all of these exceptions. So just to jump into a couple of them, just to illustrate what we're talking about here. So again, these are reasonable and necessary activities that do not constitute information blocking. So if I was a clinician, or I worked in a clinician's office or a hospital, and I had a reasonable belief that a practice of not sharing a patient's electronic health information will reduce the likelihood of harm to that patient, then I could claim that exception from sharing that information. Again, there's exceptions here related to privacy, related to security. If you are recognize that maybe there is a suspect reason why someone is asking for a particular patient's information, or et cetera. If I want to protect the privacy of that patient, I do not have to share that information. I can claim this exception. So there are, again, are 9 different exceptions here. The one in red is the newest one. That's related to the trusted exchange framework and common agreement. So if there is a request made for information between two physicians' offices, and both of those physician offices are participating in the trusted exchange framework and common agreement, and using that as a means of exchange, then it will not be considered. It would not be considered information blocking if TEPCA was used for that exchange of data versus the means maybe it was requested through. So again, both actors have to be kind of participating in TEPCA. I can talk more about TEPCA later on. But suffice it to say, there are 9 different exceptions that do provide kind of a lot of cover for maybe some of the activities that you all deal with and engage in on a day-to-day basis that do not constitute information blocking. So it's also important to note that we're talking tonight about kind of physician disincentives or healthcare provider disincentives. The non-provider actors, the health information networks, health information exchanges, or health IT developers, are subject to civil money penalties if they are deemed an information blocker. So again, if they are found to violate the information blocking prohibition, they could be assessed up to a $1.2 million information blocking fine, a civil money penalty for that violation. So there's a difference there in terms of healthcare provider disincentives and the other two actors. So it's a up to a $1.2 million fine if a network, an exchange, or a health IT developer is found to be an information blocker. For healthcare providers, what happens is that if they are seen as an information blocker, there's a referral to for appropriate disincentives to another federal agency. So there's more information. That's what we're going to spend the bulk of the rest of the presentation talking about. Let me stop right there and see if anybody has any questions right now that I can answer before we jump into any of this. Okay, I will jump in, but again, please just feel free to let me know if you have any questions. So in terms of disincentives, it's best to start with who is really considered a healthcare provider under this under the information blocking kind of definition. So the definition comes from the Public Health Service Act, and it includes physicians, pharmacists, hospitals, skilled nursing facilities, and you can see the other sort of settings and clinicians, providers that are included here under the definition. So for providers, the disincentives are really apply to three different categories of providers. So we're going to talk about hospitals and critical access hospitals is one category. The eligible merit-based incentive payment system clinicians, the MIPS clinicians, and then Medicare ACO accountable care organizations also are kind of subject to a separate piece of the disincentives rule. So the amount of the disincentives will vary depending on kind of the Medicare reimbursement that's otherwise owed to the provider. So you'll be able to see in some of the examples that I walked through. But it's important to note here that disincentives are only for providers. If a provider is not enrolled in Medicare, then they are not subject to disincentives. The only disincentives that are here are kind of through your Medicare payment, Medicare payments, your Medicare reimbursement. So that's just something to kind of keep in the back of your mind. So disincentives for hospitals and critical access hospitals. So if again, what will happen is that a allegation will be made of information blocking, kind of maybe the scenario that Josh walked through in the beginning, but apply that to a hospital. So an allegation will be made, a complaint will be made, allegation, and that will be sent to the Office of Inspector General, the HHS Office of Inspector General, to look at for an investigation. So and to determine whether there was an information blocking determination. That will in turn be sent to the Centers for Medicare and Medicaid Services for actions that will apply that will apply the disincentives. So for hospitals and critical access hospitals, what will happen is that these really come through the Medicare Promoting Interoperability Program for how hospitals are reimbursed. So an eligible hospital would have their payments reduced by 3/4 of the applicable percentage increase in the market basket update or the rate of increase for hospitals. So again, the market basket increase will be reduced by 3/4 for that hospital if it's determined that they are if it's determined that they are blocking information or had blocked information in one particular instance. For an eligible critical access hospital, they would be paid 100% of their reasonable costs instead of the 101% of reasonable costs that they normally would be paid. So again, just keep that in mind. So the scenario for MIPS eligible clinicians, has to do with kind of the meaningful use program and also promoting interoperability, et cetera. So a MIPS eligible clinician would not be a meaningful EHR user in a particular performance period if OIG refers a determination that a clinician committed information blocking during a particular calendar year. So that would result in a promoting interoperability score on kind of the MIPS performance categories of 0 for the promoting interoperability performance category. So it's important to note that we're talking about kind of the same MIPS payment year performance period structure that we normally are. So if there is an information blocking determination that's referred in 2025, the disincentive would apply in the 2027 payment year. So it's kind of the 2 calendar year kind of structure that we have now for kind of performance and payments on that. So to walk through kind of an example, just to provide a little bit of grounding on this. So a MIPS performance score is based on 4 different categories: quality, improvement activities, promoting interoperability, and cost. So, and that what also happens is that CMS will set a performance threshold, and they'll say that you need to score 75 points on that performance threshold in order to receive a positive adjustment. If you're higher than 75, you could be eligible for up to a 9% increase, a positive adjustment of up to 9% reimbursement under the physician fee schedule for that payment year. However, if you score below that 75%, you could be subject to about a negative 9% reimbursement cut under the physician fee schedule. Again, it all depends on where that performance threshold is set. So a clinician who participates in MIPS and is required to report on promoting interoperability would receive a 0 score if they're deemed an information blocker. If that threshold is set at 75, then that would be the highest score that a clinician could earn. So depending on where the threshold is set, that clinician would likely kind of be in that up to negative 9% reimbursement cut under the physician fee schedule for that particular performance year. There are a couple caveats in terms of reweighting on promoting interoperability and also group reporting. So some physicians are not patient-facing, or some physicians are practicing in what's considered small practices. So if a physician is not patient-facing, or if it's in a practice of 15 or fewer eligible clinician, that performance category is reweighted to 0. So therefore, that clinician in either of those 2 scenarios would not really be subject to any sort of disincentive from if they were deemed an information blocker. If there are some scenarios where a physician who maybe is not required but does submit promoting interoperability data as part of that category, the reweighting is canceled and they could be subject to a disincentive. Now, to turn to group reporting, so if depending on how a clinician reports data to CMS, this is where it figures into the group and the virtual group reporting. So if MIPS PI data is submitted as a group or virtual group, the disincentives will be applied at that level. So if you are functioning in a group, if you are one clinician that's functioning in a group and one of your fellow clinicians is determined to be an information blocker, and again, if you are reporting as a group, then the disincentive would be applied to all of the payments coming to that group. For those that are working with taxpayer identification numbers or national provider identifier linked to a virtual group, final score, CMS is going to use this score for the MIPS payment adjustment. Again, for those that are tied together in a kind of a virtual group environment. So it could be that we're talking about also multiple MPI, so multiple national provider identifiers. If there's a complaint against multiple national clinicians that have different MPI numbers, the disincentives are going to be applied to each of those different NPIs. So it's kind of important to note also about what happens under ACO. So in kind of the simplest terms for disincentives for accountable care organizations and for those participants and provider suppliers and accountable care organizations, they are really removed from the program. So for at least 1 year. So if information blocking occurs before a provider participant is kind of intended to be brought into an ACO, they could be denied acceptance into the program for 1 year. There's also the idea that if an ACO itself is found to be blocking information versus a kind of a participant or a provider supplier, that ACO's application to participate in the Medicare Shared Savings Program could be denied for at least a year. When that ACO or the ACO with a participant or a provider supplier were to reapply, CMS is going to look for to see if any corrective action was taken, kind of remedy the situation that the information blocking occurred. So and ACOs could have the opportunity before a particular decision was brought down on a participant in that particular ACO. CMS may issue a notification to that ACO and say that this particular provider has been determined to be blocking information. That ACO may have the opportunity to remove that provider from their kind of eligibility list prior to any sort of penalty impacting the entire ACO itself. So I hope that's clear. I'm happy to dive a little bit deeper into some of these explanations. So it's also important to note any sort of appeal structure. So there are not kind of separate opportunities to appeal a determination that information blocking has occurred. There is the opportunity through the existing kind of program processes for kind of the Medicare Promoting Interoperability Program through MIPS and to actually appeal a disincentive being applied. However, there's not really a process in place to appeal the actual ruling of being determined as an information blocker. So it could be that there is an investigation that's conducted through the Office of National Coordinator and the Office of Inspector General. They will reach out to a particular provider or a vendor or a network and exchange and say that they are looking for information about a particular instance when an allegation of information blocking has been lodged. There is no if it is determined that information blocking occurred, there's not an opportunity to kind of appeal that through the Office of Inspector General's processes. There is the opportunity to appeal the disincentive through the existing CMS program processes, but there's not that opportunity to actually appeal the determination of information blocking through the Office of Inspector General. We have tried to aggressively advocate the Biden administration, Department of Health and Human Services on the need for kind of an appeal structure or for a corrective action plan structure. we're going to continue to work on that, but right now that's the structure that we have in place. So I've talked a little bit about kind of the OIG investigations and why this is all kind of reached the forefront, and we're kind of having this webinar today is because we just got the final regulation that kind of set up this entire disincentive structure this summer in June of this year. What that regulation said was that as of July 31st this year, investigations could commence on information blocking allegations that occur against providers for conduct that happens on July 31st, 2024, moving forward. So anything that happened before that July 31st date, the Office of Inspector General is going to exercise enforcement discretion. But starting on July 31st is when those allegations could be investigated as part of information blocking. So OIG is going to focus their investigation in kind of 4 areas. They have designated 4 different areas that they're going to really focus on. Those areas are resulted in, are causing, or have the potential to cause patient harm, significantly impacted a provider's ability to care for patients, were of long duration, or caused a financial loss to federal healthcare programs or other government or private entities. So those are the 4 kind of functions, 4 kind of practices that they are going to be looking at and kind of prioritizing for information blocking and for their investigations. So it could be that it could be that one or more of the enforcement priorities is going to be kind of triggered here. And again, as I kind of mentioned before, what will happen is that the Office of Inspector General will kind of basically subpoena information from a provider, and information and documentation related to the allegation. But again, it's important to mention and remember that each of these allegations is going to be assessed on a kind of case-by-case basis. And we also have the knowledge standard for providers as knows that kind of a practice is unreasonable or interfering with the access, exchange, or use of EHI. And OIG and HHS in general has really emphasized that the kind of the focus and scope of the investigation could change after it has begun. I'm going to show some data in a minute that will kind of demonstrate where the kind of allegations have been lodged thus far related to information blocking. But it could be that an instance where a allegation of information blocking has been lodged against a particular provider, and OIG may and the complaint that was submitted is against a particular provider. Once OIG kind of digs into some of the details and looks at some of the information, it could turn out that the provider was not necessarily blocking the information. It could turn out that it was actually the information was being blocked by the Health Information Network, Health Information Exchange, or by the Health IT developer, some sort of software piece. So again, scope of the investigation can change. But again, most of the material is going to come from the provider. And again, once the investigation concludes, that's when OIG will make the referral to the Centers for Medicare and Medicaid Services. That is where kind of I spelled out the Promoting Interoperability program, the MIPS program, and kind of the ACO program as the 3 pieces of the healthcare provider information blocking disincentive programs. There is also the possibility that an investigation by OIG could OIG could refer to other federal agencies any sort of piece of the investigation. So, as an example, OIG could refer an allegation of information blocking to the HHS Office of Civil Rights, which administers and enforces the HIPAA regulations. So that's just something to keep in mind. Sometimes a complaint will be lodged for information blocking, allegation on information blocking, when it actually was kind of more of a HIPAA violation than it was an information blocking violation. So just something to keep in mind that HHS will be referring any sort of instances to other agencies for other additional actions. So the ability to report an information blocking complaint allegation is available right now. You can see the link right at the bottom of the page. This is on the Office of the National Coordinator, Assistant Secretary for Technology Policy, Office of the National Coordinator page, and an instance of reporting information blocking. And there is actually current data right through the end of August this year of allegations of information blocking. So since this program has kind of been formed, really back in 2021, when some of the rules around this were finalized, there have been over 1,000 possible claims of information blocking that have been reported thus far. So you can see this data is not really broken up from when the enforcement date started on July 31st. What we're really talking about over the past 3 years or so is over 1,000 claims of information blocking. And you can see who is making the claims of information blocking. The vast majority of claims on the left-hand side of the slide here have come from patients. Of the 1,000 complaints, over 1,000 complaints, about almost 650 of those complaints have come from patients. And then you can see, the next piece of the scale here is about third parties on patient behalfs, et cetera. And then there's also healthcare providers that have lodged complaints. And then if you look at the right-hand side of the slide here, you can see that who are the actors that these claims have been lodged against. So the vast majority, almost 900 of the 1,000 complaints have been lodged against providers for information blocking. So I show you this just to kind of provide some sort of level setting of where we're at. So when I look at this data, I think that it is probably skewed to report instances of healthcare providers, perhaps for instances when healthcare providers could not provide information to another regulated actor. So, however, I would say that when you look at the patients that are reporting to them, that are making these claims of information blocking, there probably are a host of instances and a host of number of reasons why the healthcare providers probably have been, I'll say, blamed for the information blocking in a lot of these instances, because I don't know how many patients know about health information exchanges, how many patients know about the health IT developers. So I think it's important to note that providers, being on the front lines of delivering patient care, on the front lines of care delivery in general, are maybe seen as the kind of entity that's blocking information, when, as I kind of alluded to before, it probably it could be an instance when it is not, it's kind of out of the provider's hands in terms of the blocking of information, that it could be dependent on processes that are in place from the Health Information Network, Health Information Exchange, or Health IT developer. So just kind of keep that in mind when you're thinking about that. Providers on the front lines of care are probably inordinately seen as maybe standing in the way of further information exchange. However, there probably are a lot of processes that are happening in the background from different vendors, different pieces of the healthcare IT infrastructure that are preventing the sharing of that information. So, what the rule that was just finalized this summer has also said is that there are going to once a determination of information blocking has been made for healthcare providers, there is going to be kind of a public posting of that information. That is going to include the healthcare provider's name, business address, the practices that were found to have information blocking, and the disincentives that were applied to that particular provider. So again, we are very early in the process. We don't have any sort of models or examples yet of any sort of information blocking investigations, any sort of information blocking disincentives. So what we're kind of talking about at this point is like very theoretical. But what is going to happen once a determination has been made against healthcare providers, that information is going to be publicly posted. But it's also important to note that that physicians can benefit from information blocking protections. Information blocking does not only affect patients, it also affects physicians. So all of the kind of regulated actors need to kind of participate in the broader sharing of information. And I would encourage you to reach out to your developer, your network, or an exchange to kind of ask them what they're doing to come into compliance with these regulations. So, and really try to hold your EHR developer, your network and exchange accountable for appropriate information sharing. So there isn't an instance when a patient requests information to be shared, or a provider asks for information to be shared on a particular patient, and you cannot do that. So it's suffice it to say that providers can file information blocking complaints against any sort of the entities that are covered by this rule. So in terms of next steps, there's a couple other things that I would encourage you to do. A review of your policies and procedures to ensure that you're compliant with the access, exchange, or use of electronic health information is important. And kind of outlining when and how your organization is going to apply the exceptions is also important. Kind of have a proactive plan in place for thinking about different scenarios that you engage in probably on a regular basis when you may be may need to refer to one of the exceptions or refer to kind of broader compliance questions. And then I would also encourage you to update your internal and external documentation that describes your commitment to sharing electronic health information. I think that's important. So everyone internally within practices, within maybe broader hospital environments, and also all of your patients understand what you're trying to do in terms of sharing information. And then training personnel and kind of looking at collaborations and partnerships to prevent information blocking. The Trusted Exchange Framework and Common Agreement, as I talked about, is one of those instances where it may be helpful to the broader sharing of healthcare data. That could be one kind of collaboration to look at, in addition to what you all have specifically in New Jersey. And then also refining the exchange processes that you have. Improving the processes to create and retain records and other documentation demonstrating compliance with information blocking. And then also documenting when you do use an exception within your EHR, maybe within in a clinical note or an office note or something, when one of the exceptions is applicable to maybe a particular instance of data sharing, or particularly requests for information. But I also would encourage you to identify and retain counsel to help prepare for an OIG investigation and prepare kind of your policies and procedures to something else to kind of think about, again, proactively before an OIG investigation is initiated. So at the AMA, we are going to continue to kind of advocate for broader information sharing. Broader information sharing really improves the outcomes that you all deliver to patients. So we're going to keep advocating for an even more interoperable healthcare infrastructure that supports physicians, that supports patients. I think the disincentives rule, the regulation that was just finalized this summer, will also provide opportunities for us to talk to federal officials, both in the Department of Health and Human Services and in Congress. So we're going to continue to advocate for disincentives, the disincentives construct in general that unfairly and arbitrarily penalizes physicians, results in punishments that may not be proportional to the underlying alleged misconduct, that lacks a meaningful mechanism for physicians to address allegations or appeal adverse determinations. And also, in a broader sense, this is kind of counterproductive to participation in Medicare quality and value-based care programs, since being a Medicare provider and a participant in these programs is the only way that you're subject to a disincentive. So again, I think that there are folks. I think in Washington D.C. are looking for and waiting to see if there will be any sort of information blocking actions from the Department of Health and Human Services, the Office of Inspector General. That will be kind of the beginning of more explanation about these processes, about how folks may want to be thinking about this, setting up again your policies, procedures, thinking about more ways that you can try to make sure that you're enabling the broadest sharing of health data as possible. So I think these slides are all going to be shared with you, but again, here is more information, links to all of everything that I kind of discussed, goes into much greater detail than what I was able to cover today. But again, I'm happy to try to answer any questions if folks are interested.
Jeff, thank you so much. That was phenomenal. Do you want to? Well, I actually have a question, but I don't want to cut in front of anybody else. No? Okay. All right. So I'll ask my question. Can you describe how participation in a health information exchange like One Health New Jersey would help practice or a physician avoid a charge of information blocking? And then I guess the sort of flip side, or the other side of that same coin question is, if you don't participate in a health information exchange, are there any other ways that you could realistically or practically insulate yourself from a charge?
Yeah, I mean, I think participation in an exchange or a network, it will, will make each, I think each network and exchange has different models and employs different ways that they kind of collect data and share data. But participating in an exchange, presumably will make your data more accessible, more available to exchange, and in a practical sense, make it easier for other kind of entities in the healthcare environment to access your data. So I would definitely encourage you to participate in New Jersey specific entities that are kind of focused on exchange in New Jersey. Most healthcare is delivered, in kind of a small radius around where different patients live. So participating in New Jersey level exchanges probably is going to be the best means for exchanging data. They have processes in place. They have kind of the procedures in place to make sure when a request is made that it is not overburdening to you to be able to share that information, to make that information available to be shared. So I think it's a means to an end, and kind of making sure that you're helping your patients and helping patients in kind of your network receive the best possible care, making sure that patients have the opportunity to access their information through the network or through maybe other national networks is also an important piece of this. But again, you can see from some of the data about patients maybe being unhappy with some instances of their information not being shared, not being shared between like a primary care physician and a specialist, or a specialist back to a primary care physician. Again, we don't know what all those allegations are, but I think, to get back to your question, Josh, I think the idea of participating in a network, both at the New Jersey level and also kind of in a broader national network that probably has more access to your data, is only going to serve multiple purposes and allow you to better serve your patients and reduce some of the burden that you may incur for trying to maybe answer requests for sharing of patient data.
Jeff, this is Dr. Joy. Does this sharing of information include only through the sharing of medical records, or does it include via faxes, via voice, via telephone calls? Information is shared in a million different ways, as you know.
Right. Yeah. So what we're talking about is electronic health information.
Well,
So
sometimes there's other ways of sharing parallel or not including that. I may call a specialist and give information that he may need, and he has it, and he'll document it on his chart, but that won't be done electronically. Am I liable to some not sharing information because I do it verbally or by fax and not by electronically?
So that's something that I would encourage you to seek counsel on. What I would say is that electronic health information is defined by the Office of the National Coordinator as what's included as the data within your designated record set on kind of a HIPAA from a HIPAA perspective. So that all the data that's included in what you consider your designated record set is electronic health information. Most of that is electronic health information, and there could be instances where that kind of also includes some information that may be included in paper records. How portable that information is, how accessible that information is. Is there the opportunity to transfer maybe some of the pertinent information into electronic format so it can be shared? Those are all questions that I think it would be better to kind of seek counsel specifically on. Once, as some of these allegations and some of these investigations commence, I think we'll have more information about how this is going to functional in a practical sense. But that's the best answer that I can give you right now.
May I speak?
Sure. Yes.
Yeah.
Sorry,
So
I didn't see
I'm Dr. Kathy Mazzola. I've been in pediatric neurosurgery as an attending since 2001. I'm also in my third year of law school now because I want to be a lawyer to defend physicians. I'm grateful that you spoke. This is very informative, but it makes me really angry because I don't think I think the government has really good intentions, but I don't think they know what they're doing. So number one, this is just like another part of another unfunded mandate, which was shoved down our throats, right? We had to use electronic medical records. My handwriting was perfect. There was nothing wrong with my records. But let me tell you something. When I was with a neurosurgery group and I started my own practice, and now I have over 85 employees. But when I started, it was me, a nurse, and a secretary. And in order to transfer the electronic patient medical records from one server to another server, Virtual Officeware, who is the only provider for a GE Centricity in 2005, they charged me $40,000 for a data transfer. And when I called New Jersey High Tech to complain about it and report it for consumer price gouging, what the director of High Tech literally told me, yeah, Dr. Mazzola, it's like the Wild West out there. There's no laws about what companies can charge for this, so they just charge what they can do. So now doctors, some doctors use a free EMR. Some doctors pay $100,000 a year for EMR. We have 20 providers. We're probably paying $150,000 a year for EMR. And we don't get comped for that at all. Another unfunded mandate, we have to provide translation services for free. The government, again, another great intention, no money for the physicians. Nothing, zero, no tax break, nothing. You should have a patient portal. We have a patient portal. It costs us another $20,000. Where's the tax break for that? No tax break. But now, now that we have a portal, we're more hackable. Look what happened to Optum, right? One of the biggest companies in the country was hacked, and it basically shut down medical practice and hospital billing and collection for a month and a half. We are still fighting with our cyber insurance company to get pushed through a claim. We're not getting anything. So no offense, but when you talk about physicians being punished for not sharing healthcare information, I'm just like, I just want to go run and take some Zofran, anti-nausea medication, because this is the kind of these are the kind of mandates and the kind of rules that really need to stop. You should go after Epic. You should go after Centricity. You should go after the insurance companies who don't share information. But to talk to physicians about disincentives for us, are you kidding? We're all going broke as it is. So many practices are closing.
And
So
we bend over backwards to share information. We try our best.
it's just getting
every
worse
day.
and worse. So Jeff, I encourage you to take that back to CMS, HHS, and the AMA. Really, there's not much more physicians can do.
Right. No, Dr. Mazzola, I think we hear you. I definitely appreciate those comments. I think those are points that we have tried to make to CMS, to HHS in general, and the kind of the unfunded mandate that you speak about is definitely something that we try to emphasize.
We can't afford this.
Yeah, no, I think we hear you. I'd love to kind of keep in touch as maybe as you receive more requests for sharing data or encounter kind of any sort of obstacles that in the future for kind of sharing data, or there are hindrances. Even a hindrance could be.
And it's not on our ends. I mean, we jump through the hoops. We pay for the portal. We do this. We do that. And it's a joke because all the doctors on this webinar, they'll tell you, we send the patient for an MRI. They send us a report if we're lucky. They don't give us access to the images. Even when you write on the prescription, put the images on a CD so I could look at them with the patient.
Right.
They tell you to log into a portal and it's like a million different passwords. You can't get in there. It's just ridiculous. I
Yeah.
mean, it really is, and the hospitals who are paying millions of dollars for a different version of Epic, like when Robert Wood Johnson buys Epic, they don't just buy it for Robert Wood Johnson, they have to buy it for every separate hospital. And every separate hospital then has to have the Epic trainers come and the Epic designers. And one St. Barnabas Epic works nothing like Newark Beth Israel Epic, works nothing like University Hospital Epic, and they're in the same system. So don't come after us, go after Epic.
Right. Yeah, I think we wanted to do this webinar tonight just to educate you on what the government is requiring at this point. But
Yes,
I
that is
think
awesome.
I think we hear you loud and clear. And I think we are kind of trying to get those messages across to HHS and to as I kind of alluded to, this has been kind of building for several years. I mean, this was included in a law that was passed in 2016.
If
and
you
now
ever need someone to speak, Josh knows how to get me, but I have to run to class.
Okay.
Thanks, guys.
All right. Thank you.
Thank you.
Thank you, Dr. Mazzola. Yeah, and I think Dr. Mazzola raises excellent points, and really captures them in a compelling way. These are going to be serious concerns for many of our physicians.
Yeah.
And I encourage anyone to reach out to me and to the medical society to see how we can help you, excuse me, help you avoid charges of information blocking. Because I think that's as these regulations come into effect and as complaints become or begin to build, this is going to be one of the things that the medical society ends up working a fair amount on. Because I don't see, I think Jeff has made clear that this is only going to get more intense and become a more prominent, one of the more prominent challenges that physicians face. I fear that it's going to get worse before it gets better.
Jeff,
So
what does $1 million in civil penalties imply? That if we make a mistake in not documenting a fax or a CD that's sent to us that's not conveyed, that we're liable up to $1 million? I mean, by whom? By a private lawyer who goes out and looks for these cases?
Right. Well, that $1 million civil money penalty is only for health information networks, health information exchanges, or health IT developers. Providers, healthcare providers, physicians really would be subject to the other side of it, the kind of Medicare reimbursement adjustments that we were talking about tonight. But I think I understand your question. There is a significant investment that needs to be made, and if there are situations that you encounter where where information blocking is occurring at your vendor or network or exchange, that's an opportunity for you as a physician and you as one of their customers to kind of file a complaint through that portal that ONC has available.
all right, well, Jeff, I want to thank you. If there are no more questions, I'm very, very thankful for your taking the time tonight to talk to us about this important change. As I said earlier, this recording will be saved and posted by the Medical Society for viewing later on. And I suspect that this is a video that we will be releasing a fair amount in the future because this, as Jeff has made clear, this issue is not going away. All right.
Yeah, and yeah, Josh and everyone, thank you very much for having me tonight. My contact information is included in the on the slide deck, but I think Josh and MS and J team knows how to get in touch with me. So please let me know if you have questions or encounter situations. I think having more kind of feedback from you all is only going to enhance our advocacy efforts. So additional information from you all on the front lines of delivering care, on the front lines of exchanging information is only going to make our advocacy stronger. So please reach out.
Great.
Thank you, Jeff. Thank you for sharing.
Thanks so much, Jeff. Really appreciate it. And thank you everyone for joining tonight.
Thank you. Good night.
Good night.